Morning, everyone. As I'm sure all of you, really, most of you at least know by now, my name is Evan Luther. I'm one of the chief residents here this year. I think I spent the last couple of my Grand Rounds talks on relatively esoteric research topics that really are things that I'm interested in, but that most people probably are not. So I felt that kind of my last hurrah should be used as an opportunity to focus on the trials and tribulations of residency. It's kind of been a subject close to my heart, and you'll see why. So full disclosure, I just want everyone to know that the majority of this talk will be my own personal opinions. So most of it is not absolute facts. But I think that given myself, Dan and Roberto are kind of at the tail end of residency and haven't been fired yet, we might be the most qualified to talk on the subject. First of all, I want to preface by saying that I don't think anyone here is a dummy. I just thought it was a relatively catchy title, more catchy than neurosurgical residency, the Cliff Notes, but that's probably more accurate. I think most of this talk is going to benefit the junior residents. But I also really tried to impart some wisdom for the seniors as well, since I definitely really feel like the last couple of years of my residency has impacted who I am and, who I'm going to become as a surgeon. I also really feel that the skills that make you a successful junior resident are not necessarily the same skills that make you a successful senior resident. So I'm hoping that someone, at least in the residency, can take away something from today that they help them prevent future struggles during their training. It's also going to be somewhat interactive, so please bear with me. Most of my slides don't really contain any true information. I just want everyone to feel able to interrupt or talk or ask questions or give any of their input, at any time. So feel free to chime in. So I think similar to medical school, it's really difficult to understand what residency is going to be like until you're in it. I think everyone kind of said the same thing about medical school. When you're applying, we've all heard the adage that medical school is like trying to drink water from a fire hose, but that's really difficult to comprehend until you're, up at 2 a.m. trying to memorize every bacteria, virus, and fungus known to man for, infectious diseases. I remember hating that. So we'll kind of get right into it. That being said, we'll start with the junior years. So this is the picture of me that is still listed on the website. Hopefully I look still a little bit of the same, but have more gray hair and, and more wrinkles. This was me as like a brand new intern, bright-eyed, bushy-tailed, really excited and honored that I was chosen by to be a neurosurgery resident here. And what I didn't really know is that I had no idea what I was getting myself into. This is a picture of my Jackson badge that I took on one of my first days of work. And the reason I'm sharing it now is because I really kind of feel it's like my own personal avatar through residency. I've had the same badge my entire 7 years. It's been with me, gone everywhere that I've gone, at least when I'm at work. And on this day, it was really shiny and brand new and really had no idea what the road ahead looked like. So I want to share a personal experience. I had probably not long after that photo of my badge was taken. It was during my first week of intern year. I was on cranial and a patient of Dr. Harrow's had fallen in the bathroom overnight. So, as a good nurse, as I was rounding, very early in the morning, the night nurse came up to me and said, hey, this is what had happened. He's totally fine. He looks exactly the same. I just wanted you to know. So I went and examined the patient myself. He was at his neurologic baseline. So I didn't really think much of it. And then when I went to write my daily progress notes after I'd rounded with the team, I put in that subject line, overnight events. I said, patient fell in bathroom, but at neuro baseline. So I had no idea that putting that in a note somewhere would trigger this risk management assessment and investigation throughout Jackson, where everyone rushed to this patient to try to figure out whether or not he had truly fallen. And the result of which the investigation was that the patient had not actually fallen, that he had slumped over while he was on the toilet. So unbeknownst to me, that day, a consulting service on the patient then copy pasted my note into theirs And that again triggered a further risk assessment evaluation, which then resulted in an email to Dr. Hiros that said, our service was involved in copy forwarding false information into the electronic medical record. So at that moment, I had no knowledge of the investigation or correspondence with Dr. Hiros. But the next day, when I went in to work and I was checking my email, I had received a message from Dr. Hiros who was politely requesting that I call him. I was terrified. And at the time I asked my chief, I said, what should I do? Dr. Hiros, our program director, is asking me to call him. There's this email chain that looks like I've done something horrible. And he said, don't worry about it. Don't call him. I'll speak with him and I'll take care of it. I know you didn't do anything wrong. So I kind of went about my day. And then about midday, my phone started ringing. And as you know, I'm sure you can all guess, Dr. Hiros, was calling me, and I answered the phone and I said, Dr. Hiros, good afternoon. And he calmly kind of asked me, he said, meet me at the West Wing 9 nurses station so that we can round. And I said, okay. And I thought to myself, well, hopefully it sounds like my chief has talked to him. But as many of you know, Dr. Hiros has a way of kind of luring you in with kindness right before he's going to make it known that he's unhappy with you. So when I arrived at the nurses station, he kind of smiled at me and asked and said, did you get my email? And I said, oh, yes, sir. The chief had said, and at which point he kind of stopped me mid-sentence, turned a nice shade of red, and politely told me, if I tell you to call me, you call me. I don't care what anyone else says. To which my immediate reaction in my mind was, this is it. Week 1, I'm fired. It's over. So don't worry. Dr. Hiros is not that mean. He calmly replied to me. He said, we understood. Do we understand? Okay, good. Now can we round? And we never spoke of it again. Obviously, I didn't get fired. And here, this is an example just that Dr. Hiros went back to using me as his personal mannequin during morning conference in no time. He liked to put me on the desk to show me how the lateral position was done and things like that. So to make sure that every junior resident knew exactly how to position these patients. And now these days in morning conference, he even lets me sit next to him in the chair. So, the reason I even provide this anecdote is because at the time, I really thought there was no way that I could recover from that. I felt that my trajectory as a resident, now he didn't trust me. I didn't call him even though he asked. And now I was kind of predestined for failure. I had no real idea of how to even fix the mistake because I thought I had done everything correctly. I documented what happened to the patient overnight. I deferred to my chief when they told me they would take care of it. And then I still felt like I was on the brink of extinction in residency within the first week. So then, that kind of begs the question, what makes a good resident, right? How do we define success? Does anyone want to jump in, maybe one of the junior residents, to say what they think kind of helps define success in junior residency? I don't know. Tyler, why don't you give me a couple of things that you think may define success?
Does the mic work on this? Oh, good, it does. I don't know, just showing up every day and making sure you're available to help with anything you can, and keeping the patients alive.
Great. Yeah, that's a great answer, and I think that's certainly some of the characteristics that define being successful as a junior resident, especially as an intern. So, clearly in that moment with Dr. Hiros, I really didn't feel like I was a success, and I really didn't feel like I was even doing a good job. So then the question is, how do I turn that around, or how do we even define success? I think it's interesting, if you look at the literature in PubMed, there's not much available in terms of defining what success looks like in residency, right? So much of what's out there is either looking at, career placement after residency or getting into residency, and then the question is your academic career placement at the end of residency a good judge of success in junior residency? I don't really think so. We did have this paper here at UM where we looked at intra-residency metrics. So, this is from our own department. And basically what we found is, interestingly enough, that these pre-residency metrics that everyone looks at, so STEP score, medical school, et cetera, were not really predictive of academic career placement in the end. But we did see that intra-residency metrics, so these things that we have here, administrative and leadership skills, technical skills, research, clinical knowledge, clinical judgment, and patient relationships, those were all things that were predictive of people being placed in academic institutions at the end of their residency. So again, though, this comes back to this idea: is academic institution placement at the end of residency still really the measure of success? And interestingly, I think, in this paper, the category that I felt like I was lacking in that story with Dr. Heroes, right, was this colleague relationship, right? And this was the only non-significant metric, right? The only metric that we felt like that didn't show any prediction of future academic success in neurosurgery residency. So I find that interesting because that's where I felt like I had failed, right? So again, if you type in, neurosurgery residency success into PubMed, there's very limited data on the subject, really nothing in residency, that describes how we be successful as residents. In fact, again, most of it focuses on either matching into residency or career trajectories. This was really the only review that I found that was published in the Red Journal in 2021. And again, it looked at various neurosurgical residency education interventions, but none of the papers found in this review really defined what success looks like. So, it's interesting. I won't belabor the point, but you can see here that most of these things were what they called education interventions, and what it was is that's people felt that residents weren't getting enough training in regards to radiosurgery. So then they did a targeted radiosurgery program that then allowed the residents to learn more about radiosurgery. And then they found that they then performed better on tests afterwards because their knowledge of radiosurgery improved. Similarly, there's a lot of microsurgery, skills labs. So they looked at residents doing microsurgery skills in the lab, and then evaluating them later and seeing that their skills had improved. But again, I think success, as a resident, whether it's a junior resident, mid-level resident, senior resident, is a very broad category. It's not just these very specific things that these institutions applied. So, they're really targeted, if that makes sense. And I don't think much of them define the qualities or skills to be successful in residency. So it's interesting, after kind of doing this search, it really kind of shows that, like, residency, what success is in residency is really a black box. What really happens, right? No one really has defined that or tried to put it in peer-reviewed journals. So, the question is, what are the qualities in a resident that you guys think make someone successful? I think absolutely, Tyler, you nailed it. For an intern especially, is that you're available, you're there to make sure that the patients do well. Interestingly enough, the Neurosurgical Atlas, I thought, had a pretty great definition of what a great resident is. And they have a whole page actually dedicated to kind of describing what the good attributes of a resident. But I think it's important, right? So trustworthy, efficient, independent, detail-oriented, and personable with a strong work ethic. Those are a lot of heavy-handed attributes. But I think, Tyler, you certainly checked off a couple of those boxes, right? You said availability, right? Strong work ethic, right, implies that and high attention to detail. These things apply to the ability of keeping a patient alive, right? I also think that, when I read those attributes, I think to myself that many of these things are incredibly difficult to teach, meaning that it's very hard to teach, an adult, right, a 26-year-old, resident, how to have a strong work ethic, right? I think some of that has to be instilled in you from a very early age. I remember asking my parents in elementary school if I could get paid for good grades because all of my friends were, and they responded to me with, why should we pay you for something we expect you to do? And in other words, it was very clear to me from a very early age that my parents expected a strong work ethic. They didn't feel that hard work deserved special treatment. And I think it was those kind of interactions, for me personally as a child, that really helped form my internal desire to excel. It was really this idea that for me, I wanted to be good because I was doing good for myself, right? And there was nothing else that drove that. So I think, in neurosurgery, again, it's fairly self-selecting. So I think most people who go into this field already have much of these attributes. So the real question is then, how do we build upon them, right? How do we make sure that we nurture these attributes and grow them so that we continue to be excellent in what we do? So, when I think about the first one, which is trust, right? Trustworthiness. This quote always comes to mind. Rome wasn't built in a day, and for me, neither is trust. I'm a firm believer that trust in the operating room is built in your junior years. I'll say that again so that you guys can hear it, right? Trust in the operating room is built in your junior years. What that means is that if you can prove during your junior years of residency that you can safely and effectively take care of attending patients in the ICU and on the floor, then they'll be much more inclined to let you operate on their patients as a mid-level or senior resident. The converse is also true. If you don't demonstrate the ability to take care of patients before and after surgery, then you'll likely experience less autonomy in the OR. So then how do we build trust, right? Because it's not just about taking care of the patients, it's conveying to the attendings that you're doing the right things for the patients. So I think, especially in the modern day era of iMessaging and WhatsApp, trust begins and ends with communication. So as an intern, if you can convey information in a concise and effective manner, then I think that translates into trust. This is one of these things that I kind of harp on you guys in morning conference to try to tell you that you need to be able to have a single sentence that describes what a patient's neurologic exam and what their imaging findings have. So that when you are a junior on call at 2 a.m. and you call an attending to wake them up because you think someone needs emergency surgery, you can say a single sentence, and that attending doesn't even have to open their eyes. They can picture the exam and picture the CT scan or the MRI, right? So this also really corresponds to that first A that we mentioned, right? Back on the neurosurgery, right? The ability, right? That neurosurgery is rarely convenient, right? That we work long hours, we work nights and weekends. It's not a convenient job. It's not a convenient specialty. So learning that early is important so that you can respond in a timely manner to questions or concerns. That really demonstrates that you're efficient and responsive. And this doesn't really apply only to interactions with attendings. I think if you can act this way to other staff throughout the hospital, they'll often give feedback to our attendings about how good you are, right? Your presence will be known throughout the hospital, not just in our department. So, I don't know if you guys know who this is, but this is Gizmo the Gremlin. So I don't know if you guys are familiar with the 1980s movie Gremlin, but junior residency, we all know that we're consistently sleep deprived and stressed. And we know that gremlins are sweet and cuddly, but they can turn into unlovely creatures if you give them water after midnight. So I think junior residency is similar to this. As a resident, you may have a dark side. I think we've all got it, right? We all have a dark side to us. That most of us have worked really hard to keep hidden or to try to get rid of. But once you're hungry and sleep deprived and one more writer consult comes in at 3 a.m., you can turn into this guy, right? So how do we prevent that? I personally think that some form of meditation can help. I don't think it has to be meditation, like this guy here sitting on a rock, with his legs crossed, eyes closed. But my personal view of meditation is this thought or is the belief that meditation is a thought or action that helps me align my external behaviors with my internal thoughts about myself. So I think what that means is, generally speaking, right, if I think to myself, I'm a pretty good human being and I'd like to treat people with respect and dignity, but do my actions reflect that? Am I actively treating people with dignity and respect? And if not, then maybe I need to find a way to better align these things. I think sometimes it's counting down to 10 and taking some deep breaths before I call back that 3 a.m. consult. Other times it's reflecting on my day and asking, why am I having negative feelings? If I am having those negative feelings, is there any action I can take to change those things that have disturbed me in that day? There's something that I can do differently. So I think this is, one thing I wanted to point out to you guys, and this is one of my ways of meditating. This is an example of a note that I wrote to myself as an intern. So you can see the date there, August 20th, 2016. So I was, 2 months into residency, and the notes I wrote myself, you can see here. As a chief, I want to give explicit plans to my juniors during rounds so that I can relay it to the attendings effectively. Build my juniors up. Do not bring them down. Do not be condescending. That is not in your nature, and you shouldn't let it become that. Once a week, call your intern to the OR and let them scrub. Don't make your intern wake up your patients unless they help with the case. That isn't your job. So, I think in my mind, this kind of behavior that helps me, one, clear my mind and allows me to really have a focused goal and understanding of what I want to be as a resident, as a neurosurgeon. And I also think that it is this kind of behavior that helps you become more personable. And it really leads you to that second A, right? The availability, the affability, right, is what we're focusing on now, right? And I think self-affirmations can also be really helpful. It sounds silly, but no one got here because they were stupid or lazy, right? So no one got to neurosurgery residency because you were bad at what you did. It's good to remind yourself sometimes that you are a good person, that you have a lot to offer to the world. The caveat to this, and another way to build trust, I think, is especially among the residents, is also recognizing your own limitations and asking questions when you don't know the answer, right? So as a junior, there are still many things that you may not know, right? And no one's going to fault you for that. But what is important and what can become dangerous is when you don't know what you don't know. What I mean, in other words, is it's important to identify your gaps in knowledge and try to fill in the blanks, right? This self-sufficiently and independent learning will help really establish a habit of inquisitiveness that will only continue to help you in the future. So I would be remiss if I didn't mention this concept. As I'm sure many of you have heard Dr. Wang speak about this, I think the Dunning-Kruger effect is certainly applicable here. So for those of you that are unfamiliar with the concept, it describes the relationship between confidence and competence for a specific task. So obviously, in the context of residency, I think junior years put you somewhere here to the left of Mount Stupid. So what that says is that, as a junior resident, initially, right, when you know nothing, you have zero confidence and no competence, right? So you're running around like a deer in headlights, don't know what's going on, but you also know that you know nothing. What happens is that as you start gaining a little bit of confidence, that snowballs much faster than your competence does. So as your confidence skyrockets, your competence still remains relatively low. And I think it's important to try to combat this, right? This effect. So, you really have to ask yourself, do I really know as much as I think I know? And part of that is asking questions, right? Asking questions to your seniors, asking questions to your attendings, and, learning on your own, right? If you don't have one of the things that I love to do with juniors is that if we have a question on rounds about a disease or something that's going on, I immediately try to find articles for it and send it to them, right? Send them the articles so that they understand the concept of what's going on, so that they know and they have some concrete evidence to back up what they're stating. So I think on the topic of balancing confidence and competence, I think it's especially important in neurosurgery to also talk about the balance between deference and disagreeableness. So as you can imagine, I think most attendings and senior residents prefer deference because, let's be honest, they really have more experience than you do as a junior resident. However, if you think you have a good idea or you think something should be done, feel free to speak your mind. I think here's a great synopsis of being disagreeable that I found online. It says, what does it look like to be disagreeable? It is crucial to note right away that disagreeable does not equal unpleasant. There is no reason to be an aggressive jerk when you disagree, and people who are highly disagreeable are definitely more likely to be fired. The lower you are on the totem pole, the more crucial this is to remember. An effective, disagreeable person knows that they can be friendly, outgoing, pleasant, and disagree when necessary. So I think in the context of neurosurgery, it's important to remember that as a junior resident, you really are an advocate for your patients. You spend more time with them than anyone else on service. So it's really important to stick up for them, even if it means you have to disagree. I have another little anecdote, of my personal experience, just an example of disagreeableness. As an intern, I had a patient on our service who initially presented with severe hydrocephalus and an altered mental status and was found to have a large colloid cyst. It was resected. She initially improved a little bit, but never really woke up. Her EVD was weaned. And then she went to the floor and kind of became this dispo issue where she was on the floor for a while and never really gained consciousness back and was very altered. And I remember thinking to myself, as an intern, maybe it's worth ordering a CT scan, because there was this period where she improved a little bit and then she got worse, and maybe something, untoward is going on. So I ordered a CT scan on her and it came back and she had florid hydrocephalus. Her ventricles were larger than they ever had been, and she needed a shunt. And I distinctly remember when I conveyed that information to my chief, he was incredibly upset with me for ordering the scan, because now he had to add on a case and do a shunt. I probably in that moment probably should have communicated a little bit more effectively that I thought we should get a CT scan. But when I look back on this moment, I'm able to recognize that my disagreeableness in that moment likely helped that patient get better. So again, speaking about communication, I think it's incredibly helpful to really write out instructions for your day-to-day activities on service. These are notes that I wrote to myself and then passed on, for posterity's sake, for almost every rotation that I had in residency. I think not only does it really help you as a reference to look back on, for yourself, but it can help your fellow residents succeed and also allows you to reflect on what is important throughout the rotation. So these are just some notes here on cranial, my notes at UMH. It's much different now, but here are all these numbers of all the MPs, the schedulers, the nurses, and then even here in my year of endovascular, I wrote out kind of notes to all the future fellows so that they have kind of an idea of what's going on. I think for me, this is extremely helpful because it helps me articulate what I've been doing. It also helps me understand, are there areas that I could improve on? And then it also lets me look back later on to see, how things have changed. So also remember that even as a junior resident, you should take time out for yourself and the things that you love. Something I wish I would have done more as a junior is definitely ate healthier, exercise more, and focus more on some of my hobbies outside of work. I remember thinking to myself, it's just, I don't do anything but work and sleep. But to be fair, when I look back at some of my junior years, I still got married and I still got to travel. We even went to Alaska and got to see the pigs in the Bahamas. So I think it was pretty still successful in that. The other things that I would tell you is that, don't forget to stop and smell the roses. I know that sounds incredibly cliche, but even at work, you can find glimpses of kind of the natural world around you to help you stay grounded. At least for me, sometimes being in nature really helps me kind of, understand my place in the world. And this here is just a video of the canals right by UMH where I could find a manatee swimming through the water. I don't know, but for me, it always seeing that always reminds me that one, I have my place in the world, and it's this pretty small place. And for me, that humility helps ground me and keeps me humble. Okay. So, as you make your way out of the fog, that's the junior call at Jackson, you start to find yourself in the middle years of residency. I think you've effectively become a neurosurgical teenager. So how do we define success here? I don't know, maybe one of the mid-level residents can say that. I don't know, Vignesh, are you there? If not, maybe Eva or some other mid-level, or Cater, one of you guys can chime in. What do you think defines success in your mid-level years?
Yeah, I think part of it's like preparing and, reviewing, all the imaging before it, going over, like looking on Neurosurgical Atlas or anything to just try to understand the case and know what exactly you're going to be doing in the plan.
Yeah. Yeah. And you find it's different than success in the junior years. That's a question.
Yeah.
Sorry.
Oh yeah.
Yeah. I mean, I would tend to agree. I mean, I think that, in my mind, as Tyler pointed out, right, that I think success in the junior years is proving that you can successfully take care of neurosurgery patients who may be incredibly ill, right? And you can do that effectively and efficiently. But the mid-level years is where you kind of start heading into the operating room, right? You're doing much more, you're involved in the surgeries at a much higher level than a junior resident. And I think you're absolutely right. You start transitioning to a different kind of what I would say is responsibility, right? Meaning that your responsibility now is to understand, much more about the surgery, right? So I think, I come back to the Dunning-Kruger effect because I think this curve is really helpful in that, the mid-level years kind of really start putting you somewhere between the peak of Mount Stupid and the slope of enlightenment. In other words, I really feel like this is where you begin to understand how little you know of neurosurgery, right? I remember as a PGY4 being thrust into the angio suite and listening to everyone speak in what felt like a foreign language, I need the O2 this or the O88 that, or we need to use the DAC for this or the synchro. I needed you to open a synchro. And I felt like a fish out of water. I didn't understand any of the language, and it took a lot of patience and tolerance of my own shortcomings to get through this. And a lot of also learning on my own. So here, this is just my personal example of the valley of despair. I really thought I knew how to do surgery until I cut through the STA and couldn't stop it from spraying all over me. All jokes aside, though, I really do think that these years are kind of the jumping off point for most residents. And it can really be a fork in the road, pun intended, for many people. I think, and for me, this is a poem, by Robert Frost. I won't read the whole thing, but I'll read at least the last paragraph. I shall be telling with a sigh, somewhere ages and ages hence, two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. And I think, for me, what that means is that, as a mid-level resident, I think you're at this point where it can be easy to sit back and go on cruise control. But I think if you keep working hard, you can really excel. These are the years in which you can really disappear within the program. At least here, I think what I mean by that is that, there is much less supervision of your day-to-day activities, and nearly all of your learning is self-directed and self-motivated. So I think, if you become complacent, in these years, you can really solidify bad habits. And those bad habits can really, snowball, once you become a senior resident. Alternatively, I think you can use these years to really, truly hone your craft, right? Find your niche within neurosurgery and strive to become excellent at it. Then the question is, how do we do that, right? How do we become excellent at what we're doing? I think that's really multifaceted. I would say that, there are really several avenues by which this is done. From a research standpoint, I think you have to be consistently asking yourself, why do we do things a certain way? How can I make this better? How can I come up with a better solution? These focused questions can really help guide you towards a project that may change the practice of neurosurgery as we know it. My personal goals in residency, for research has really been focused on better defining endovascular treatment and successes and failures for aneurysms. The gold standard is biplane angiography, but I remember, during my endovascular year, there's this question of, what is really going on at the neck of an aneurysm? We did all these follow-up angiograms on these patients who had, pipelines or flow diverting stents placed. And why do certain aneurysms continue to fill after flow diversion while others thrombose completely? And I feel like it's these questions that really help drive my passion, one, for research, and two, for cerebrovascular neurosurgery in general. So I think these are also the years in which habits are solidified, good or bad. And I think, as a result, it's really important to ask yourself every day, what could I have done better? As as Bart Simpson is doing here, right? He's writing, I will not cut corners while he's cutting corners. So, remember that cutting corners in the operating room now will only lead to future pain later on. And, just like Eva, just like what you said, be responsible, right? This meaning of responsibility takes on, I think, a much bigger role in your mid-level years, because it's no longer just about patient care, right? Patient care is now the expectation, right? Now it's about understanding the surgeries and also being able to manage your junior residents, right? So, I implore you guys to be more involved rather than less involved, in the services and what's going on in your mid-level years. The other side of this is also, I think, debriefing is really important, following a surgery. And what I mean by debriefing is that, it doesn't have to be formal or even really immediately after surgery, but I think it's really invaluable to ask your attending or your senior resident, what could I have done differently? How did you make that one move that opened up the whole case, right? That, I saw how you got through that one step. How did you know that you could do that safely? Right. And I think it's asking those questions and understanding those concepts that really help you as a surgeon begin to progress. The other thing is that I think an important part of debriefing is taking notes, right? So, write down what instruments are used, the pitfalls during a surgery, the places where you see yourself struggling or see someone else struggling, so that the next time you do a similar case, you're even more prepared than before. I think neurosurgery is iterative, right? What I mean by that is that things continue to build upon themselves. So many surgeries will build upon one another. And if you write down notes for each of these procedures, you can become better and better, even with surgeries that you may not have done before. So this is just like an example, right? Of like writing down the notes, right? This is what I wrote down for endarterectomy. And this is just, in purely looking at the things that I need to have in the room. But just having this detailed reference of, I need all of these instruments helps me go through all of the steps of the endarterectomy, because if I have that instrument, then I understand what the next step is and what I need to do with it. And then I think it's really important to remind yourself that you're operating on a person and not a pathology. What I mean by that is that for you guys, this may be just another work day, but to the patient that you're operating on any given day, it's a life-altering event, right? I think that we as surgeons, and especially neurosurgeons, have the gift to spend more time with our patients than any other specialty in medicine. I mean, if you think about it, right, most of our surgeries, on average are at minimum 2 to 3 hours, right? So even if we do 3 surgeries in a day, that means we're spending 2 to 3 hours with each patient that we interact with if we're in the operating room. I remember in medical school, in medicine, we would round on in each patient's room, we would spend maybe 15 to 20 minutes. We would see, 8 to 10 patients in 3 to 3 hours. And then we would spend the entire rest of the day writing notes. We would be sitting in front of a computer typing, and we wouldn't even be with the patient. Now as a resident, at minimum, I spend half of my day with each patient operating on them. And I think, I know that the patient is anesthetized, right? They don't experience, the fact that we are there with them, but you are experiencing it, right? And these people are at their most vulnerable, right? They've signed consent. They have, neurosurgical problems that are incredibly serious, and this is intimate, right? They're giving their life to you. And I think reminding yourself to be honored that these patients are putting their lives in your hands, and really they're putting the organs that are responsible for who they are, how they move, how they essentially experience the world, they're putting it in your hands. So I think it's really important to remember that every patient is a person. And all jokes aside, right, with Urkel here, it's even more important to debrief on your complications. At this stage of your training, you really are independent enough to be able to hurt a patient. And trust me when I say that when complications occur, your world becomes very small. The first serious complication I caused was an embolic stroke during a follow-up angiogram with for an aneurysm patient, young woman. She woke up aphasic, and we got an MRI, and she had an infarct right in Broca's area. And I was absolutely devastated. I remember talking to Dr. Peterson and feeling so upset because I couldn't even identify what I did wrong. I hadn't done anything different in that case than I had in the last 200 diagnostics that I'd done. In fact, if anything, it had probably gone smoother than most. And I remember him walking into the angio suite that day and saying to me, one, Evan, I had the exact same complication happen to me in a super VIP patient. So I know what you're going through. And two, I know that you're super careful. Think about how many of these you would have already caused if you weren't. You know, this is neurosurgery. It's a high risk field no matter what you're doing. And so, I've got to remember to myself, even the simplest procedures can have drastic consequences. But we have to learn forgiveness and work through those complications and develop patience with ourselves in order to continue to succeed. So not only do we have to learn patience with ourselves, but I think it's really important, especially as a mid-level resident, that you also learn patience with other residents or medical students. To be honest with you, the only way that I've effectively been able to do this is to actively remind myself what it was like to know nothing or next to nothing. Neurosurgery is so specialized that I think everyone's default begins to be this, that we forget to speak to or interact with the novice. I think you have to actively work to combat this because you're responsible for teaching the people that will eventually replace you, right? Even as a mid-level resident, right? So learning patience with people and understanding that everyone learns at a different pace, I think is important as well. This here is just a picture of people being patient with me as I learned how to braid patients' hair. Never braided before. Here's a picture of me trying to be patient with Arya as I taught him how to remove a drain on his first day of residency. And then here is lastly me, unfortunately, losing my patience, putting in yet another EVD on call. So I also think in the mid-level years that this is where you really should begin to understand indications for various surgeries and start being able to recognize the thought processes behind when and when not to operate. For the latter, again, I'll never forget Dr. Peterson using this quote with me is the idea of never underestimating the courage of the non-combatant. This was in reference to neurologists requesting us to do mechanical thrombectomies for nearly every stroke that comes in the door. And the point being is that they ultimately have no skin in the game, right? They're not responsible for any complication that can occur during that procedure. And so it's really up to you, right, the surgeon, to decide whether the risk of the procedure is worth it in each case. This is a similar quote, I think, by Teddy Roosevelt, which is again, something I love. It says, "It's not the critic who counts, not the man who points out how the strong man stumbles or where the doer of deeds could have done them better. The credit belongs to the man who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, because there is no effort without error and shortcoming, but who does actually strive to do the deeds, who knows great enthusiasms, the great devotions, who spends himself in a worthy cause, who at the best knows in the end that the triumph of high achievement, and who, at the worst, if he fails, at least fails while daring greatly, so that his place shall never be with those cold and timid souls who neither know victory nor defeat." I love that. Also, last and certainly not least, now that you have some more time on your hands, it's time to rekindle those old hobbies or get new ones. Do something, but be good to yourself. Allow yourself to decompress so that you can be refreshed and reset when you come back to work. This is just a picture of me playing paintball. As I'm sure many of you know, it's a thing that I love to do all the time, and it's really how I decompress on the weekends. Here's a pic of Dr. Levy and Dr. Manzano rap battling. At least that's what it looks like to me. It was in morning conference. Clearly, they know how to decompress. And even more important, I think don't let life pass you by, right? These are the years where you have a little bit more time on your hands. Go visit your friend's newborn baby, right? You'll never see them this young again. You'll never be this young again, and you'll never have these opportunities again. So don't miss out on these things. Participate in life. So with that being said, now this kind of brings you into senior residency. So Now that you made it through the mid-level years, you have a few more gray hairs, a few more liver spots, but a lot more knowledge and surgical skill. You're finally a senior resident. So is the success of a senior resident different than that of a mid-level? I don't know. Is there someone on here, maybe Arya? If you're on, what do you think? Is there a difference in those types of success? Is he on? I don't know. Okay, maybe Christian or someone. I don't have many senior residents to pick on. All right, fair enough. Well, I personally think that it is, and for me personally, as a senior resident, I think that what what defines success, even more so than the mid-level resident, is the amount of responsibility, not just in the surgeries, but with the team. So I'm going back to my little avatar. You can see now that my badge is completely faded. You can barely make out my face. The color's almost unrecognizable. My badge has officially been through the ringer. And I think now, hopefully by this time, you're kind of coming out of the valley of despair and you're somewhere in the slope of enlightenment. And I think these last 2 years, I'm calling PGY 6 and 7, as the last 2 years of senior residency have really allowed me to make leaps and bounds surgically. To be honest, I think the actual surgical skill was probably present by my mid-level years, but in my senior years, it's really that confidence increase that allowed me to make that move that was uncomfortable but necessary for the surgery to progress. And I think this is here where that third A finally comes in. So I think it's very interesting, right? If you look back, those 3 A's that was talked about in the Neurosurgical Atlas and that Dr. Komentar talks about frequently, right, is that availability, affability, and ability, right? The availability and affability start in your junior years, right? And the ability continues to grow. But, for me, I didn't recognize it even in myself, the ability, until I think PGY 6 is really where I started feeling comfortable and confident in a lot of surgery. So again, this is where it comes back to, right? This is where trust, the trust that was built in your junior years really comes into play. I think now all that hard work from building trust before with your attendings and co-residents pays off, as now you really have more autonomy and independence and more complex surgeries. So, believe in yourself at this moment, right? Believe in your ability, but don't be afraid to ask questions, right? We have the training to do what is necessary, but remember that, that it's a fine balance between, doing something dangerous and doing something confidently. So what I mean by that is I also think at this stage that it's very easy to rest on your laurels and believe you've learned enough, right? I think it's incredibly important to remain teachable. In fact, what I mean by that is that I'm certain that the techniques that we're doing today in many of the surgeries that we do are going to be relics in 10 to 15 years, right? So, I know Dr. Komentar has said this multiple times that, the way he does surgeries now is incredibly different than the way he did them 10 years ago. So if you don't remain teachable and you're not willing to learn new things, you too are going to become a relic, right? So I think also what coincides with remaining teachable is that you have to be receptive to feedback. It's incredibly important. And be specific, right? In terms of getting feedback and giving feedback. How could I have been more efficient in this move? It took me a while to get to this point of surgery. What could I have done differently to get there faster? Right? Asking those questions, right? Debriefing more and being more specific about very specific parts of surgery will help you continue, to gain confidence and to gain skill. I also think it's incredibly important. This is what I was kind of alluding to, in the senior years, that don't forget to protect your juniors, right? Your junior residents, right? They're effectively an extension of you, right? So especially as a chief, you're ultimately responsible for all the patients on your service. If an attending is unhappy with how a patient is being managed, that is your burden to bear. It's not your juniors, and they're often just enacting plans that you developed. So don't be afraid to speak up on their behalf, right? this is just an example of recently, right? We did a hemicraniectomy for a patient, and Dr. Peterson, he said, nice job, Evan. And the truth is, it really was Tyler in Turkey. It was their case, it was their patient, and it was they who got the patient to the operating room. I was really just there for moral support. And it's important, right? Build your team up, right? You're only as good as the people you surround yourself with. And if you work to elevate your peers, then everyone benefits. So, and last but not least, don't forget to have life outside of the hospital. This last year, our oldest dog died, and we were devastated. But we decided to get 2 new ones, and now we have these little rascals here, and they brighten our lives every day. Explore Miami. You're in a wonderful city. Go out, see what Miami has to offer. Be on the water, be in the moment, right? You're never going to be this young again. You're never going to be able to have these experiences again. So do it. Do the thing that you want to do. And this is just, an example. Kat and I went rock climbing. There was a rock climbing gym down south a couple of weeks ago. It's something I haven't done in years. We decided we were going to do it. Do the things that you love, rekindle those old hobbies, again, continue to be the person that you want to be. And that's really the end. You certainly know that these two know how to stay grounded. So with that, if there's any questions, I'm happy to take them, but I hope someone has gained something from the talk.
That was really, truly amazing talk, and congratulations. I don't think I'd ever been able to picture a talk with repeated memes like that and pull it off. I just want to let you know that my next talk is going to be all TikTok. And
Perfect.
I'm going to one up. No, but sincerely, great messages. I hope the residents were listening, and I hope that Gladys can put this in a way that people who missed it can get back on and listen again.
Thank you. I appreciate
it. Evan, that was really great. I concur with Alan. At least you already showed how far you've gone along because of your deep analysis of your own journey. That is in itself a huge quality for residency, is ability to reflect and self-analyze along the way. And you've been really a master at this. This is a fantastic model for the residents. Also, if I can add, there's a beautiful quote from Maya Angelou when you listed the things, the qualities a resident needs to have. It probably applies to life in general anyway. And she said courage is the most important most important virtue of all, because without it, you cannot exert the other ones consistently. And it's true. So if I can, read that quote, it's really good in the sense that you can, without courage, you cannot stand what you believe in. You cannot say that you screwed up. You cannot say that it's really underlies every other virtue. Anyway, but listen, congrats. Very nice talk.
Thank you. Yeah, one of my favorite, I don't even honestly know where it comes from, but one of my favorite quotes is that courage is not the absence of fear, it's action in the presence of fear.
Right.
I think that certainly applies. So, well, thank you guys for letting me talk on a subject that wasn't necessarily research focused, but certainly I felt was helpful for me at least.
Evan, I want to join my voice with everyone else. I'm not a neurosurgeon. I'm here to give a talk, but I was lucky enough to log in early and I caught a lot of this. It's fantastic. It's a great pep talk. I can't wait to get back in the lab and do stuff. And all I was thinking the whole time is maybe we should have this for PhDs, because our valley of despair is a little steeper and wider. So it's fantastic. I might ping you offline to ask you. This is great.
Absolutely.
Great point, Hassan. Evan, that was fantastic. I mean, you touched upon a lot of life lessons for us all, regardless of what you're doing in your workplace, to really enjoy life, appreciate every day, appreciate friends and family, and what's happening outside the University of Miami. It's so very important. So thank you very much for that very thoughtful presentation. Anyway, with that, we'll kind of continue this morning and move to our research presentation. And it's really my honor to introduce Dr. Hassan Ali. Hassan is an associate professor, and he's dedicated his academic career to understanding how best to conduct drug discovery programs. And he and his colleagues, which we'll talk about today, have been very successful in developing strategies, computational analysis, and approaches to understand the complexity of therapeutic targets and move some of the therapeutic interventions forward. So Hassan today is going to talk about leveraging polypharmacology to resurrect the spinal cord's regenerative potential. So Hassan, with that, thank you very much.
Thank you, Dalton, and thank you, everybody. I'm honored to be here and giving this talk. Are my slides showing in the correct format, the presentation mode for everybody?
Yes, it looks great. Everything is
perfect. So my name is Hassan. I'm an associate professor of neurosurgery and medicine. I'm a biochemist by training, and my focus is drug discovery and therapeutic development. So my lab here at UM focuses on drug discovery in three main areas. My primary appointment is in neurosurgery, and I'm a member of the Miami Project, where I work primarily on CNS drug discovery and development. I'm also a member of the CATS Drug Discovery Center, Division of Nephrology, where I work on nephrological drug discovery. I'm also a member of Sylvester Comprehensive Cancer Center, where I work on some oncological programs. And today I'm going to tell you about our main CNS program targeting spinal cord injury, which I started working on a little over 10 years ago with two neuroscientists, John Bixby and Van Slammen. And I'm lucky that I get to continue collaborating closely with them today. And we were later joined by Jay Lee, who is the lead on our animal model work and efficacy testing. And this team has just been fantastic throughout. So the story of this project boils down to the history of how we solved two main problems that I believe have been a major hindrance for the development of therapeutics that can promote nerve regeneration in the central nervous system, be it for treating spinal cord injury or any other CNS injury. And the first problem is specific to our disease, to the pathobiology of spinal cord injury, while the other one is more general to the discipline of drug discovery as a whole. And I don't need to tell this audience about the complex pathobiology of SCI. We can all agree that a complete and comprehensive cure will likely require multiple treatments, addressing neuroprotection to reduce neuronal loss, inflammation and scarring, regeneration, and then rehab to prune and train the regenerative tissue. Let me just figure out how to move this from here. Okay. But I think we can also agree that no matter what ends up being our overall treatment approach, be it tissue restoration, bridging with biomaterials, or reconnecting with microchips and computer interface, all of these approaches will likely benefit from and potentially critically require some amount of regeneration to reconnect spared nerve tissue. The problem, however, is when axons in the CNS get severed and damaged, they do not regenerate very much, and this poses a very strict upper limit on recovery from SCI, and will likely also limit the efficacy of any restorative approach that does not contain a pro-regenerative component. And in recent years, it has become clear that there's at least two main mechanisms that suppress axon growth in the adult CNS. One is referred to as the intrinsic regenerative potential, or the intrinsic pathway. And these neurons, as they develop and age, they just lose that intrinsic ability to regrow their processes. And the other one is called the extrinsic pathway. And this is just the presence of inhibitory molecules in the CNS milieu that signal to the axons not to grow after they're cut. So our solution was to develop a therapeutic with a dual mechanism of action, because it has become apparent that therapeutics that target one or the other of those pathways at a time were not showing sufficient clinical efficacy. And to that point, this analysis may be a year out of date now, but the home take point is going to be the same. So this is a list of clinical candidates that have been in development or just entering clinical development for targeting regeneration in SCI. And what you'll see is that all of these candidates, except the one that we ourselves are developing, are targeting either extrinsic regeneration or intrinsic regeneration. So Bioaxone was for a while developing a molecule that targets the Rho kinase pathway, and that has failed a couple of years ago. Novartis and GSK had a monoclonal antibodies targeting inhibitory molecules in the cord. BioArctic and Kringle Pharma were playing around with growth factors, and those have all been languishing in clinical trials, and none of them have really gone anywhere yet. Last year, there was a press release from AstraZeneca where they found that one of their ATM kinase inhibitors that they were developing for a separate indication, they decided that it could be potentially repurposed for promoting axon growth in SCI, and they had some data on that in a mouse model that seemed positive, and they're moving that now into a clinical trial. And it might be fair to say that at the moment, that's our main competitor in terms of a small molecule that is targeting axon regeneration as the therapeutic mechanism for treating SCI. And we have a little bit of data on this compound that I'll show you later in the talk. So the other major problem is that drug discovery is a very expensive and fraught with failure discipline. And one of the main bottlenecks that the pharmaceutical industry is still struggling to solve is how to identify the optimal drug targets, the components of the cell that you want to engage with your drug candidate to result with a therapeutic outcome. So an analysis done on drugs that were approved between 2010 and 2014 found that the median time it takes from starting researching the biology of the disease to identifying a potential drug target is 25 years. That's a lot of time. And most of the time, the targets that get identified are not the ideal ones that you want to pursue in a drug development program. The rest of the pipeline is more or less worked out and streamlined by the pharma industry. So you have 2 to 5 years validating your target, a couple of years performing high throughput screens to identify your starting chemical matter for your drug development, a couple more years of preclinical development. Here's, when you do chemistry, try to improve the properties of the molecule so that it's safe enough to put in humans. Then you have your IND, and FDA allowance to start clinical trials, and the average time there is about 7 years. And if you're lucky to gain approval, you're likely to have spent about $1 to $2 billion. So when this process fails, it's unbelievably costly, and everybody all the time is trying to figure out how to make this more efficient. But reducing the chances of failure and also reducing costs. And something that now everybody likes to do is to really think long and hard about what is the shape of the drug that we're trying to develop, what is what's called the target product profile of our drug, how are we going to deliver it, who are exactly going to be our patients, what are the expectations for safety, what is the exact route it's going to go through, what is the dosing schedule going to be like, and so on and so forth. And then by working backwards, we can make sure that we are honing in every step of our development process so that we're minimizing waste. And fine tuning the properties of our drug to really fit that final target profile. But that still doesn't address the elephant in the room, which is that if you have a suboptimal target, the whole thing is likely to fail. And you really want to know that as soon as possible before you start investing all these monies. So what we did was to develop an entirely new biotechnology platform that now we know can take that period of 25 years and cut it down to less than a year in some cases. And the principle for this technology is simple. We call it IDTracks. And basically, we just sidestep all of the phases of trying to understand everything about the biology of the disease, the involved signaling networks, all the genes that are at play, and try to get to the answer of what is the ideal drug target in the most direct and most empirical way possible. So, here's an example. In our case, we're looking for things that can make the axons or the neurites of neurons grow longer. So we isolate primary neurons from rats, we culture them, and then we treat them with compounds. In our case, with kinase inhibitors, because kinases are my favorite family of drug targets, and you can ask me why. I can tell you if you're interested. But we in this case screen with hundreds of kinase inhibitors, and we identified the ones that make the axons or the neurites grow longer, which we call them hits, and the ones that don't or make the axons shorter, and we call these non-hits. And then what we do is that we profile those compounds with all the kinases in the human kinome, which contains about 500 to 550 different kinases. And what these colors are showing is that, blue means that compound 1 has no activity on kinase 1. And then as you have more activity, the color changes to yellow. So compound 1 has a little bit of activity on kinase 2, and so on and so forth. And when you look at the data like this, you can start to see patterns. So you'll see that compounds that inhibit kinase 10 and kinase 18 in this example are promoting neurite outgrowth. So you can start to form hypotheses that these are potentially good drug targets. But something we didn't think of going in is that when you look at the data for the other set of compounds, you can first refine your hypotheses. So you see that kinase 18 is not really driving this process. It's just being inhibited by everything. So really you narrow down on kinase 10 as a potential target. And something else is that it started revealing things in the opposite direction. So we started finding targets or off targets that drive the opposite phenotype. So in this case, kinase 7, it appears that if a compound inhibits it, it can actually give you the opposite outcome. And the nice thing about this is that, this is something completely novel. People in drug discovery hadn't been thinking about it, but really, if you have knowledge of both what you need to engage and what you need to avoid, you can really start to design the super effective drugs. You think of the target as the gas pedal and the anti-target as the brake, and you want to make sure to hit the gas without touching the brake, and that's how your axons are going to grow as fast as possible. Obviously this is a mock example and it's oversimplified to demonstrate the point, but the real data is a lot more noisy and it's not easy to pick out by eye. So I collaborated with a buddy of mine who works at Amazon machine learning and likes to dabble with those kinds of problems, Hossam Nassif. And we came up with an algorithm that can really take this complicated and noisy data and point us to specific kinases that are potentially good drug targets, and also those that we need to make sure that our drug stays completely clear of so that it doesn't undercut the drug's efficacy. And the benefit of this method, other than the fact that it's much faster than anything that the pharmaceutical industry is using, it also has a much lower false positive rate, because whatever you discover using this method is directly druggable. And that's because you discovered it using small molecules. So you know that you can design a small molecule to engage it. And it's effective, because if it wasn't effective, it wouldn't have risen up in this algorithm. So really, it's, part of the power of this is that it's really making the process much more efficient and much faster than what most target identification methods currently do. So the specific assay that we used in this platform is an assay with primary neurons that we isolate from rat embryos, and we grow them on poly-D-lysine. So this is not a super permissive substrate for these neurons to grow their neurites, which is good because this is how we analyze them using our algorithms, and the fact that these neurites don't grow very long on poly-D-lysine means that if you do have a growth promoter, you can see a very large effect. And you don't even need digital analysis here to see it. This is one of the compounds that induces a very strong growth promotion. And having this big assay window means that our assay is extremely sensitive to identifying things that are going to promote axon growth and neurite growth in those cultures. So using this assay combined with the machine learning algorithm that we developed, we screened a couple thousand compounds and fed that data into the algorithm, and it identified a number of targets. The first one that caught our attention is Rho kinase, and this was a nice internal validation of our approach because Rho kinase was already known to be a target for axon regrowth because it is a part of the pathway that controls extrinsic inhibition of axon growth. So it was nice that it popped up as one of the targets. Another one that caught our attention is S6K1. It's another kinase that is in the AKT-mTOR pathway. And that was extremely interesting. One, because it's part of what is called the intrinsic pathway. And up to that point, everybody had assumed that because S6K1 is downstream of mTOR, and because, as everybody knows, you need mTOR activity to activate the intrinsic pathway and get robust axon growth, people had assumed that S6K1 activity is also necessary for axon growth. But what we discovered is that in this context, S6K1 acts as a brake on the system. So S6K1 inhibits upstream of this pathway, which shuts down mTOR. But if you inhibit S6K1, you actually release this pathway, you activate mTOR, and that goes directly to promoting neurite outgrowth. And in this case, S6K1 activity is not required for it. It also pointed us to a number of kinases that we must not touch with our drug to make sure we get the maximum amount of growth, because these kinases are involved in pathways that support axon growth. And I'm just showing a couple of examples here, which are P38-MAPK and MAPK kinase. So, the obvious question next was, well, we have a target in the intrinsic pathway, we have a target in the extrinsic pathway. What's going to happen when we co-engage those targets? So we identified a very selective inhibitor of S6K1 and a very selective inhibitor of ROC, and we tested them in our neurite outgrowth assay. And as you can see in black, this is the effect of each compound separately on neurite outgrowth. Each of them induces a little bit of neurite outgrowth, but when we combine them together, in the blue curve, you see that you start to get neurite outgrowth at an earlier concentration, and also you reach a higher level of neurite outgrowth, which is suggestive of synergy. So, this was the first validation of our initial hypothesis that if you can modulate both of those repressive pathways at the same time, that's when you're going to get, the maximum effect of neurite outgrowth in your system. And we like those targets for pursuing them in drug development because they already have a lot of validation in the clinical context. So ROC already has an inhibitor that is approved in Japan, Fasudil for cerebral vasospasm and stroke. And S6 kinase already has several candidates in phase 1 and phase 2 clinical trials for liver cirrhosis and oncological indications. So when you talk to someone in the pharma industry that you're pursuing a compound that inhibits one or two of those targets, they're going to be more amenable to listening to you, because otherwise, if you're starting with a completely unvalidated target, that requires a lot more clinical validation. So we were lucky with those two targets, and we decided to move forward with them in our program. So, you know, now we made the decision that we're going to pursue these two targets together, because that's really going to allow us to efficiently lift the repression on axon regeneration in the CNS. And the question was, okay, how do we want to do this? Do we want to develop a combination of two drugs to do this? Or do we want to develop a single molecule that has activity against both targets at the same time? So each one of those approaches has its cons and its pros. When you're developing a combination, it's easier to find compounds that, you know, will inhibit each one of those targets and then combine them together. But the problem there is that each compound is likely to have its own toxicity profile, its own pharmacokinetic profile. And then when you combine them together, it's going to be hard to line up their pharmacokinetics so that they're doing their job at the same time. Also, the toxicities of each of the two compounds are going to add up, making it more difficult to manage their risks in a clinical setting. And finally, you worry about drug-drug interactions. You know, the more drugs you give to the patient, the more likely that's going to happen. And as I said, this is going to be a complex disease with a complex treatment plan. So you really want to simplify each therapeutic modality as much as possible. So with polypharmacology, it's harder to design one molecule to engage multiple targets, but it really simplifies the drug development. So we started searching for a molecule that can co-engage S6 kinase and Rho kinase. And because both of these two are kinases and they share the ATP pocket, there's homology between them. So it's possible to design drugs that inhibit any given pair of kinases. And which is another reason why I like this family of drug targets, because of this versatility of targeting. So we identified one molecule, which I'm going to call RO48. That was initially developed by Roche for a completely independent program. And we found that this molecule is a strong inhibitor of Rho kinase and S6K1. And for reference, I'm showing you here the data again for the individual inhibitors of Rho kinase and S6K and the combination. And when I add RO48 in the same experiment as to test how much it promotes neural outgrowth, you can see that it vastly bypasses either compound alone or even the combination. So this huge addition in effect, you know, part of it could be due to the fact that, as I mentioned, it's more favorable to fold the pharmacology into a single compound, because that improves the kinetics of target engagement inside the cells. But there's also a possibility that RO48 has one or more additional targets that could be contributing to its massive effect. And we're continuing to investigate that. And just to show you a visual, because I think it's extremely striking, you know, this is just an image that we acquired from one of the cultures where you see that the controls on top were treated with just the vehicle, and the bottom, this is what the neurons look like after 2 days of sitting with RO48. So the effect on neural outgrowth is truly massive. So going back to the question of, well, how is RO48 exerting its effect in the neurons? Is it really through these two suspected targets? So we investigated this question using a very cool technology that was being developed by Promega, and we collaborated with them to implement it in our systems, in our neurons. So the purpose of this technology is to allow us to directly measure the extent that our compound is engaging those targets inside live cells, so that we can have a one-to-one correlation between target engagement and the effect that we're observing. And the way this works is you express your target kinase fused with a nanoluciferase, And then you add a small molecule tracer that binds to that kinase. So then nanoluciferase will emit blue light. The tracer will absorb that light and will emit red light. And then you add your compound to the culture. If your compound can get into the cell, if it does bind your target, it will replace the tracer and the light will go from from red to blue. So by titrating your compound and looking at the change of light from red to blue, you can very accurately measure how much your drug or compound is engaging your intended target inside the cells. So we did this experiment for S6K1 and for ROC inside the live neurons, the same neurons that we use in our primary assay. And we found that RO48 is indeed engaging those targets very potently and very strongly in those cells. But what was really interesting is that when I put the graph for effect on neurite outgrowth, and I look at the range of concentration where RO48 is promoting neurite outgrowth, it matches perfectly the range of concentration where this compound is engaging those targets inside the live neuron. So this adds more and more validation that our compound is indeed working via these two targets. And now my graduate student, Abdiel Badiou Martinez, is continuing to lead these experiments and this investigation to look into additional targets that could potentially be contributing to RO48's activity. Also, we were interested to understand beyond those two targets and the initial act of engagement, what happens downstream of that is resulting in this massive outgrowth of neurites and axons. And so graduate student in the Lemon Bixby lab did this experiment where he took some RO48, treated cultured neurons with RO48 or with vehicle, and performed RNA-seq expression analysis to look at what pathways are being upregulated or differentially expressed. What he found was there was a large number of pathways that are involved in neuron projection development, axon development, neurite extension, and regulation of axogenesis that were being strongly upregulated with treatment with this compound. And these are probably at least partly due to the inhibition of ROC kinase. We also found that a couple of pathways related to junk signaling are being upregulated, and a previous postdoc in the lab had shown that Jun activation is actually pro-regenerative and conducive of neurite outgrowth. So this also lined up well with previous evidence we had. And it also probably explains why the algorithm identified MAP kinases as things that you absolutely don't want to engage with your target, with your drug. Finally, we saw that there's strong activation of the insulin receptor signaling pathway. And basically what this is the famous PI3 kinase AKT-mTOR axis. And this is likely to be the result of inhibition of S6K1, which, as I said earlier, releases a brake on that pathway and activates it. So, moving forward, the next step was, okay, to see, we have this massive effect in culture. What does this compound do in vivo models of SCI? And the field has always struggled with reproducibility and in terms of demonstrating efficacy of drug candidates in animal models. And there's a lot of reasons for that. There's the variability of the models, and also when effect sizes are small, you're likely to miss them in some experiments and catch them in some. So what we wanted to do is to demonstrate that the robustness of the effect of our drug, which is potentially due to the robustness of its mechanism of action, could translate into a number of different models. So one model we tried was the pyrimidotomy, which is championed by Jay Lee here at the Miami Project. And the benefit of that model is that it has short survival time. It doesn't require that much post-op care, and it's very quick as a test to see, okay, is our compound causing any axon growth in vivo or not? But it's not as relevant to spinal cord injury in humans in a clinical context as other models. Other models we've used are the funiculotomy, where the CST tract is cut at the C level in the spinal cord, and then a more severe version of it, which is the hemisection, where you go a little bit deeper into the gray matter, and that results in less spared axons, which raises the bar a little bit more for recovery. So you have more functional deficits in these models, which allows you to have a bigger window for checking if your drug is causing behavior recovery in those animals. So the concept of the pyramidotomy is that you lesion the pyramid on one side, and that causes the axons descending from one side to die off, and that leaves a gap. And then you label the axons in the contralateral side, as you can see here on the right. Do you see my marker? Oh.
No.
No,
Do you
no,
see?
yeah.
Can you see my mouse?
No, maybe you have it in your second screen, or right click.
I found it here. Can you see it?
Yes.
Now we can, yes.
Okay, so you label the axons on the contralateral side, and you see, this side of the CST is labeled. And what happens is that you have sprouting from the uninjured, unlesioned side into the side where the axons had died off, and you can quantify this sprouting. And as I said, that gives you a very quick way to check if your compounds are active in vivo before you move them into the more complex models. So the first instance of testing this compound in vivo was done in 2014, where Jay took this compound and infused it into the lateral ventricle of mice that received the pyramidotomy injury. And this was the first time that we saw activity in vivo, where we noticed that the animals that received the compound had a doubling of the sprouting of their axons into the contralateral region. And in this case, we didn't know much about the pharmacokinetics of the compound. So we just went with, we guessed the dose, we guessed the time, and we just infused the compound into the CSF for 28 days, and we saw this effect. We later learned that the compound is actually very unstable in CSF and plasma. So I guess we got lucky that we saw an effect, but potentially also because we gave it continuously for 28 days, that allowed enough compound exposure in the tissue to see an effect. But thereafter, from this experiment, after we learned that, we started delivering that compound by intracortical injection into the brain parenchyma. And that's what was done in the next experiment, which was conducted by the late Xiaoming Xu and a trainee in his lab at the time, Wei Wu, who is now an assistant professor at Indiana University. And they did here the severe dorsal hemisection, where they cut the tract at the C5 level, and they gave the animals either RO48 at a low or a high dose, or a selective inhibitor of S6K1 or vehicle control. And what they found was that the animals that received RO48 had very substantial regrowth of axons through the lesion site and well past it. And here, in the images, if you look, you see like maybe there's potentially a dose-dependent effect, but it doesn't show up in the analysis. And the way these images are analyzed is that, they take the red line from the lesion site, and then they draw equidistant lines away from it, and they count the number of axons crossing at each line. And that's what the figure to the right is showing, that the animals that had RO48 had more axons crossing through the epicenter and way further down. There was actually nothing observed for the vehicle, which is expected, and nothing observed for the S6K1 selective inhibitor, which further supports the hypothesis that you really need to engage the two targets at the same time to see real efficacy in those kinds of experiments. So the really interesting part is that this histological phenomenon of axon regrowth was also accompanied by functional recovery in these groups that received the drug. So one test that they did was the rotarod, where you put these mice on a spinning disc. And when they're not injured, they're really good for staying there. You see, on average, they stay about 100 seconds before they fall. So this disc will spin faster and faster until they can no longer hold on. And then after you injure them, they can't hold on much. So you see that after 1 week of injury, when they're tested again, their values plummet to 10 seconds. And then you have a little bit of spontaneous injury, which you notice in the vehicle and the group that received the S6K inhibitor. But then you notice a very significant improvement in the groups that received RO48. And it does appear here that it's somewhat dose dependent. So you see that the group that received the high dose has slightly better performance by 8 weeks after the injury. And I should mention here that those animals in this experiment received one single injection of the compound. So whatever that compound did, it did it from a single injection that induced enough plasticity that was reflected in the histological analysis and here in the functional analysis. Another experiment that they did is the pellet retrieval test, where the mice are placed in a box with a slit where they can reach out and grab a food pellet. And usually they drop it around 50% of the time at baseline. 1 week after injury, when you test them again, you notice that their performance drops a lot. And again, there's some level of spontaneous recovery of function. But what still strikes me about this data is that the animals that received RO48 recovered significantly more success rates. And the one that received the high dose pretty much went back to baseline levels. So in this one case, we have nearly a full recovery of function on a single administration of this compound. Another question that we always get asked is, okay, does your compound require a priming injury event? Is it going to only work in acute conditions, in acute patients, or can it potentially be used in chronic SCI? So this experiment was done by a previous postdoc in the Lembics lab, Carmen Ma, who performed that pyramidotomy experiment, but changed the paradigm where rather than give the drug immediately after the injury, the animals were injured. We waited 8 weeks and then we gave the injection of the compound, and then we waited another 5 weeks and we did the histological analysis. And pleasantly enough, the compound had this similar effect, which at least potentially suggests that this is something that could eventually also be used in the context of chronic SCI. So I don't want to bore you too much with the details, but I do want to make the point that the compound has been now tested in multiple models of SCI, and these were done in different labs, and they're performed by different surgeons. And there's a lot of data on this table, but just know that each row represents one experiment. And I just need to summarize the outcomes. I don't need to talk about all the details. So each experiment was designed to answer a different question. And the overall summary is that RO48 promotes axon sprouting or regrowth when delivered into the CNS, whether intracortically into the brain parenchyma or infused into the CSF. It does not require an acute injury event to induce regrowth of damaged axons or sprouting of spared axons. And the effect on axon regeneration is indeed accompanied by functional recovery. Another thing we wanted to look at is there a way for us to track target engagement in vivo? Because this is something that's going to be important for drug development down the line. And we know that S6K1 is a very specific kinase for protein called S6. So we looked at the phosphorylation of S6 in animals where we've injected increasing doses of RO48, and we saw a dose-dependent decrease in phosphorylation of S6. So now we could use this as not as a biomarker. I don't think it's just clinically translatable, but it's as a marker for target engagement, at least in the animal experiments for our preclinical development work. And the last question we needed to answer before we move into serious drug development is, okay, this is all done in rodents. We do know that these targets exist in humans and that are expressed in human neurons, but is everything we're seeing in rodent neurons going to translate to human neurons? So we tested RO48 in an assay that we developed using iPSC derived glutamatergic neurons from human origin. And we saw that in this case as well, RO48 had a massive effect on promoting neurite outgrowth. So now we had everything we needed to go into the Blueprint Neurotherapeutics program. And this is a very nice program that was started by NINDS to stimulate development of CNS drugs, because the field has fallen behind other areas of drug development, and pharma companies are skittish about taking up new assets just because of the continuous failures, not just in SCI, but Alzheimer's and Parkinson's and whatnot. So the point here is to simulate drug discovery and early development in academia and gears things to the point where pharma industry is likely to pick them up. And eventually a lot of other institutes joined in, like NEI and NIA and so on. And the philosophy of this program is that academics are really good at innovating and finding new targets and new processes, but they're terrible at doing drug development, and the inverse for the pharma company. So this program kind of slots in between and cleans up the act of academic drug development to the point where it can go into a pharmaceutical drug development. So they give you money for your own lab to do the assays that you're expert on, and they surround you by a network of CROs that'll do everything else that a pharma company does. So you end up functioning as an early stage biotech, and they create a team from the university lab and from there, from NIH and from the CROs that kind of leads the development of this. And I'm proud to say that this is an extremely competitive program, and there's only 7 in the nation, including academia and industry. And University of Miami is one of those 7. And we're working on moving this SCI asset towards a clinical trial. So we had done some chemistry on our molecule before entering this program, but really since we went in a year and a half ago, things have exploded in terms of moving things forward. So we've done a lot of chemistry. So first thing we did is this ring here in the center of the molecule in the parent compound was a 7-membered ring, and that is a very difficult ring to synthesize. So, and it's very expensive to make, so it has a lot of implications for drug development later and drug manufacturing. So we wanted to change it. We were able to make it a 5-membered ring without losing any of the beneficial effects on neurite outgrowth. This ketone group here makes a lot of chemists and drug people queasy because it could have, unintended effects on metabolites of this drug in vivo. So we're trying to change it into something else. We're looking at these rings here. If we can get rid of one of them, make them simpler, or modify the groups around them. And we're also trying to make modifications to this part of the molecule. This is something called the hinge binder in kinase inhibitors. It binds a very specific region of kinases that is called the hinge region. And we're trying to figure out, if we can also make this simpler or different to improve the potency of our molecule. We've also done some formulation work. So we made one compound that is slightly better than RO48 in terms of stability. We call it SBP 926. And what I'm showing you here is what happens when we inject either RO48 or SBP 926 intrathecally into mice, and then we take samples from the CSF and plasma and brain tissue and spinal cord tissue at specific time intervals and see where the drug is going over time. And what you see is that in the CSF, RO48 is chewed up immediately. So you don't, it's in red, you don't see it even at the first time point, it's gone. SB926, you detect it, but then it goes away from the CSF, quickly. But then you chase it down, you notice that it went to the plasma, so it got effluxed into the blood. But you look at the brain and you notice that some of it actually went into the brain tissue and some of it also went into the spinal cord tissue, but not that much. But when we played around with formulation to make it more soluble and more bioavailable, and that's the black line, you notice that now it's staying much longer in the CSF. That's why it doesn't go out to the plasma as quickly. Instead, it ends up going into the brain and staying there much longer, and then into the spinal cord and staying there much longer. So this kind of shows how you can improve your delivery of the compound, not just by playing with the properties of the molecules itself, but also with the formulation, the delivery, and whatnot. And when we started, we wanted to see, how much better have we done with SBP926 compared to the original parent compound. So, I don't want to get too technical, but I want to show you that we improved solubility, which is a major issue because the parent compound was not that soluble. So you want your drug to be soluble so that you have flexibility with formulations and whatnot. We improved a lot of things in terms of microsomal stability and plasma stability and whatnot, and those have implications on the delivery of your compound if you're delivering it orally or IV. But we're not doing that anymore, so this has become obsolete. But something important is that the initial compound had off-target activity on the heart channel, the HERG, which could have cardiac side effects, and we managed to get those out completely from the new molecule. And that's a couple of generations ago. We have better compounds now. But to the point of that I made at the beginning of the talk, that you can make your drug development much more effective, cost-effective, and efficient if you think harder from the beginning at where you want to end up. So, case in point, we were not doing that before the program, and we were focusing on things that are irrelevant. So a good outcome from being in the blueprint was that they forced us to sit down and really chart out where do we want to end up with our drug. And they want us to think about what's the minimum acceptable result and what's the ideal result. The ideal result is what you try to work on towards, and the minimum acceptable result is what you're gonna, make your go, no-go decision. So if you can't even meet the minimum acceptable result, that will kill your program. So you want to have a little bit of cost-benefit analysis about where your minimum acceptable result is and what would make sense. So we've worked a lot with the blueprint team, and we got a lot of help from the clinicians here in neurosurgery and neurology, doctors Alberto Martinez and Jim Guest. Nuancing the efficacy metrics, expanding the adverse events based on considerations specific to patients with SCI, and performed cost benefit analysis about what levels of pain and spasticity would be tolerated versus how much gain in functional recovery. And this is a living document. It's continuing to be developed, but just having this has completely reshaped our testing funnel, which is the critical path from where we are now to where we want to end up in a few years, hopefully. So now you see that the first part of the funnel is cyclical. Basically, the chemists are making compounds that they send to us. We test them in the assays. First, the primary assay with rat neurons, then human neurons. Then we check the effect using nanobreath on the targets. If they look good, we do tier 1 ADME, and this just means that we look at the physiochemical properties of the compounds. Are they soluble? Are they likely to be effluxed from the CNS? So, this is an example of how knowing the target product profile influenced the design of the funnel. Now that we know that we will deliver the drug intrathecally, we no longer care about liver stability or plasma stability, because we're going to give it intrathecally, which means we can also give a smaller amount and reduce systemic effects on tissues that are outside of the CNS. So we don't need to worry about heart side effects as much, kidney, liver, and so on and so forth. So by making that strategic decision in the target product profile, we were able to hone in our funnel here better. So this cycle goes on, and we've made maybe 200 compounds so far, and eventually we're going to move 4 of them into the first level of in vivo testing, and that's going to be with the pyrimidotomy experiment, because as I mentioned, this is a quick litmus test on whether the compounds have maintained in vivo activity. And then the ones that look good will go into more detailed ADME and tox testing. So we want to make sure that they're not engaging the hERG channel or CYP liver enzymes or anything like that that could preclude their development into a drug. And then eventually one compound is going to be moved into the more clinically relevant rat contusion model when we will do pharmacokinetic and more detailed tox. And hopefully, it will be successful, and then we can move into large animal dose range finding. We initially proposed mini pig, but then eventually this got changed into dog. And once we have the dose ranges worked out, then we can put together our GLP and IND finally application to the FDA, with the hope that we can get into a phase 1 clinical trial by 2026, I want to say. So the name of the game is speed. They really want you to go through this program as fast as possible, and kind of like a startup, they want it to fail sooner than later, because they don't want to keep investing money in projects that are not likely to succeed. So they have very strict milestones, both in terms of effects that you need to hit and the times that you need to get them. So we've really been working very hard, making every portion of this funnel as efficient and as quick as possible, from making the assay turnaround time really fast, use really nice equipment for running a lot of our assays. We make use of robotics that are available here at the Miami project and the high content screening core and whatnot. But also we are trying to make the slowest part of the project faster, which is the animal testing. And thanks to support from Dalton and the Miami project, we were able to set up 2 surgical rigs specifically for doing those rat surgeries. And you can see Jay here working on one of them. And we're also trying to bring in as much AI and machine learning as possible to make the process of analyzing the in vivo data faster and more efficient. So in the past, one part of the pyrimidotomy experiment is that you have to quantify the number of axons that got labeled so that you can normalize the sprouting in the spinal cord to them. So we take a section of the medulla and we count the number of axons that are labeled green here. And in the past, we didn't have, the kind of fast and efficient microscopy that we have now at the Miami project. So we would take a small, image like the white square in the entire medulla, and we would count those manually, and then we would multiply by the area of the, I'm oversimplifying, of course, but that's the principle. We would multiply by the area of the medulla to kind of get a sense of how many axons were labeled. As you can imagine, this is underpowered and not as precise, but it's all you could do. But now, because we have the Dragonfly confocal microscope, we can take an image of the entire medulla. And I have an engineering graduate student working with me who's developing algorithms that can just in a second, go through this and identify the axons and count them and give us an accurate count of the exact number of axons that were labeled in an animal. In terms of analyzing the tissue in the spinal cord, again, this was all being manually done. So you had to take the image of the section of the cord, rotate it so that it's lined up, draw 3 lines at specific distances from the central canal and count the number of axons that are crossing each one. And then you compare those across animals. Again, it's underpowered, but what can you do when you're doing this manually? So now I have a undergrad, Cole Fosser, who's extremely talented, double major in neuroscience, who's also using a lot of AI and machine learning to manipulate those things automatically. So he figured out a way to, automatically rotate the section into the orientation we wanted. The algorithm picks out the side of the cord that we want to analyze, and then it traces the sprouted axons automatically. I don't know if you can see it, but there's a red trace on top of them, and that's all automated. That takes 1 second. So work that used to take us weeks and months can now be done in a few minutes, thanks to those algorithms. And finally, I mentioned to you before that we were using the pellet retrieval test as one of the metrics for measuring functional recovery. But what we found is that the animals can do quite a bit of cheating in that test, because they could still succeed in retrieving the pellet, but they could be doing that by, for example, doing a scooping movement rather than a gripping movement. They can pronate more, or supinate more. And if you're just counting success, then you're missing a lot of nuance about, are the animals recovering and how are they recovering? Are there compensation mechanisms at play? And in the end, it's fine if there's compensation, but you want to know, because, function is function, but it's good to know how this function is being recovered, because that all feeds into our design of the clinical trial. Because we don't know how these things in the rats are going to translate into humans, and what we really need our outcome measures to be. So this is all going to be very important information. So with the help of Patrick Ganser, a new faculty member here, we are switching to using the Valentus MotoTrack system. And these are modular systems that use computer supervised training and testing for forelimb movement in rodents. And this allows you to isolate a lot of more nuanced metrics, such as the grip strength, the movement speed, and the pronation and supination. We're in the process now of switching our behavioral testing to this, which again will hopefully speed up our in vivo testing. Finally, I told you at the beginning that arguably the main competitor for us right now is AstraZeneca's compound that's already passed the phase 1 for a different indication. So they claim they will be doing phase 2 testing, efficacy testing soon. And so the Blueprint program just as a competitive analysis wanted us to get some of that compound and test it in our assay to see what it does. And just as a point of interest, I wanted to show you this piece of data. So this is what we get. It's a decent 100% increase of neural outgrowth in our assay, but this is what our compound does. So and again, this goes back to the story of how important it is to have the right polypharmacology and make sure that you're engaging all the relevant pathways to a given process that you're trying to modify to get a therapeutic outcome. So as you can see, at least in our assay, our drug is 300% more effective. I don't know what that translates to, the in vivo or in the clinical context, but that for sure made everybody happy when they saw that data. And I don't know if I'm running out of time, maybe not, but I'll stop here and I'll take questions. But I want to thank everybody. There's a lot of people that have worked very hard to make this project a success. Everyone in my lab, Lembic's lab, of course, John and Vance, who have been there from the beginning. I was their postdoc in 2010. And the Lee lab, Alberto and James, who have been helping us a lot now that the project have moved into the translational phase. And of course, big thanks to the Miami project and neurosurgery leadership, and Dalton has been very supportive. The Office of Innovation, Norma Kenyon, has helped us a lot initially to get started, to get enough early drug development data to be able to convince the NINDS to invest in this project. And of course, our industry and academic collaborators. And I will stop here and take any questions.
Hassan, thank you so very much. That was just a fantastic presentation that told us about like everything we want to know about drug discovery. I mean, it's just fantastic. And congratulations to you and your team on all this work. And, big congratulations on receiving this very large, very competitive grant from NIH that's going to allow you to take this compound all the way to a clinical trial, hopefully. So let me just open it up for questions for people, maybe the first time they've heard this story.
Could I ask a question?
Yes, please. Ellen, go ahead.
Oh, I just wondered, is there any indication of whether or not the neurites that grow out get myelinated?
It's a great question. We have not looked at that specifically yet.
Thank you. It's a very interesting talk. Thank you.
Thank you.
On slide 18. Yeah, go ahead, please.
This is Ashish. I'll just get a quick question. I think it's really great work, and I think your screens are pretty novel. My only question is in terms of, kind of recapitulating the human kind of neuron development and injury. In the rat model, I think it's kind of at least it seems as a gold standard. But I guess, is there any effort to kind of use kind of a human model to screen your compound?
No. The FDA doesn't require us to do a non-human primate or even pig. I think as long as you have, as far as I understand it right now from our conversation with the blueprint, as long as you have 2 models and we have the mice and we're going to have the rats, rodent models, and then you just have to do the dose range finding in a large animal model, and then that could give you the okay to go into phase 1. But I don't think we are obligated to do non-human primates or a large animal model for spinal cord for efficacy testing.
In vitro, like neurite, organoid, or neurite, in vitro kind of work. Sorry.
So we've spent a lot of time, and we've continued to spend time developing, axotomy models, axons on a chip, and things like that. But the reality is, when you get into an animal, people don't care about organoids anymore. But to your point, it would be nice to create those models with human neurons. So that's something that we will be working on using iPSC-derived neurons. We're actually working on that right now, where we grow them in an axon isolation chamber. The axons goes to one side, and you just suction them, which mimics axotomy, and then we can. So it's not an organoid, but it's an axotomy model for the human neurons.
Awesome, thank you.
But you did show that iPS neurons seem to be responsive to your drug, correct?
Very. Yep.
Yeah. So that's a move in the right direction. I was interested on slide 18, where you showed the temporal profile of improved forelimb function, which was pretty impressive. It looked like to me that you were seeing a pretty significant improvement at as early as 1 week after the injury, or maybe after you gave the RO48, I think. Is that surprising that you would see such an improvement in function so early? Yeah. So you got the 2 week mark there. Maybe that's the one I'm looking at.
Yeah. So that's a great question. And the thing is, we don't open the animals up until the end point. So we don't know how much axon growth happened in the meantime to be able to correlate, that specifically to axon growth versus some other plasticity going on. So it's a great question that I don't have an answer to at the moment.
Mm-hmm. Mm-hmm. Yeah, when usually we kind of see things that happen very early, sometimes we start blaming it on a neuroprotective effect of the compound. So, it's just something to think about. And last question, we can talk offline about this, but yesterday we had a presentation by a group for the Executive Director of Research Cabinet meeting on drug discovery at the medical school. It was a very elaborate presentation, well done. And at the end of the day, this group wants us to spend $27 million over the next 5 years to improve drug discovery at which of course I'm very supportive of, and you would be as well. But getting back down to the individual principal investigator and investigators working on drug discovery, what do you think we need to invest in tomorrow that would help you and your colleagues move this science forward?
Wow, I wasn't prepared to answer that question, Dalton. Can I answer that offline?
Sure. Is it more chemist at the some.
So yeah, that's definitely something that I've struggled with for a long time, is that we don't have enough chemistry. And the problem with that is that everything else that you do along the drug discovery development pipeline, you can do as a a fee for service, which means that you retain IP. The problem is that when you start to do chemistry, that's innovation that you cannot claim under fee for service. So whoever chemists work with you, they can retain some of, whoever is coming up with those structures will retain IP, and then their institution will retain IP. So then is just losing so much IP because of that specific point. Everything else I've been able to go out and do either via CROs and now via the Blueprint program. So I have, it would be extremely convenient for me is if a lot of those services are present in-house, but it's not a make or break. But having better chemistry would be the most return on investment, in my opinion, in terms of keeping IP within And I'm talking here drug development, not drug discovery, right? Because drug discovery means finding the initial starting point. But the IP starts happening, with what you do from there. How do you modify that molecule into a new patentable drug?
Very good. Well said. Thank you very much. Okay, before we close, any other comments or questions to Hassan?
I just wanted to go back to your previous question and say, to the point on protection versus regeneration. So I don't doubt that there could be a neuroprotective process in action, but I don't think it's direct because I've tested our compound and those targets don't seem to be involved in neuroprotection in isolated neurons. But one can think that if their processes are, regrowing and then they're touching something that's contributing to them staying alive, then that could be some indirect effect on neuronal viability.
Very good. Thank you. Okay. Well, again, Hassan, thank you. It was fantastic. We heard two outstanding lectures this morning, and I hope everybody has a great rest of their day. Thank you very much. Take care.
Thank you all for listening. Bye.